So today I have started my recording first, even before I will forget. Okay, so today we are going into labor. So we are coming to look at labor and its related things that we need to know when it comes to the NCLEX. Remember what we are doing here, we are looking at what the NCLEX is going to demand from us or what we need to know when it comes to the NCLEX. There are things that probably we do here, especially if you are in Ghana, that I'll say it and then maybe it might not be what you've learned from the world or from, our training in Ghana. Understand that what we are learning, it's it's much more of the US things, okay? It's not different from what we've learned in Ghana, but just that sometimes one or two things that, differs a little bit in terms of what we know. So we are starting with labor and we are this slide is very simple, just to talk about the various presentation. As we all know, that when someone is pregnant and then it is time for delivery, or how the fetus presents. Okay, we all need to know. We all know. And so when you are monitoring your client and you get a question, I always like to use case study question, and then they tell you that the client, is in labor. And then assessment, presentation is, let's say, cephalic, you know what it means. Presentation is, let's say, the person is coming with breech. We all know what breech is and all that. So when it comes to labor and birth, we are first looking at fetus presentation, how the fetus presents. Okay, so we know that the fetus can either present with the head, the buttocks, or even the shoulders can be the first part that will come up. Okay, so it's either the fetus is presenting with what you call the head, and then or it's presenting with the lower extremities or the buttocks. It can all be what you call fetal presentation. So the portion of the fetus that enters the pelvic inlet first. So during labor, which part of what you call the fetus enters the pelvic, okay, enters the pelvic inlets first, and then which part of it comes out during labor first. As we all know, when we talk about cephalic presentation, we mean presentation whereby the head comes out first. So cephalic is the most common one. A fetal presentation that is cephalic in nature is normal. It doesn't come with any form of complication. Mostly, that baby or that fetus will be delivered via SVD, unless there are other associated complications that will demand that the fetus be delivered via cesarean section. And so when it comes to the cephalic presentation, even though we are saying the head that is coming, but which part of the head that is coming? It can be the vectors, it can be the face that is coming, it can be the brow, or we have the military presentation. These are not of much interest, okay? They are not going to ask us about much of these things, but just for us to know an overview of what presentation looks like, okay, when the baby is coming. So your baby can present with a face, okay, or it can present with the vectors can present and all that. Then we have the buttocks, which is not quite good if, let's say, you are reading your question and the fetus is presenting with the buttocks, which is breech. And so with breech presentation, it's mostly done, I mean, via cesarean section, right? So delivered by cesarean section, although vaginal birth is often possible, but we don't want to encounter complication. So when you notice that the fetus is coming with the buttocks or it is breech presentation, we quickly arrange for cesarean section just to prevent complication. Breech presentation also has different variations or which side is coming. And so it can be the flank side that is coming, or it can be a full breech presentation that is a complete or footling. Some of them also present with their feet as well, where you have the feet coming up. Okay, so that is also how breech presentation will also look like. You can also have a fetus that comes with shoulder. So we call that shoulder dystocia. So we'll talk about shoulder dystocia in our subsequent, presentation, or my subsequent presentation. I'll take shoulder dystocia and then talk extensively on shoulder dystocia and how you're going to deliver a baby or a fetus that presents with the shoulder. Okay, so shoulder can also be, the parts that will be presented. The fetus will lie in a transverse position, or the arm, back, or the abdomen, or the side could present. So you could have a baby who is coming, and then you have the shoulder that is rather coming out first. Okay, the shoulder side that is coming out, which is also something that sometimes they can rotate. Okay, you can rotate the baby or the fetus back, to the normal position where the head or the to the cephalic position. So if the fetus does not spontaneously rotate, it is impossible to turn the fetus manually. Okay. And so a cesarean section may need to be performed. So for people or for fetus that present with a shoulder, if at the time of labor they don't rotate back to a cephalic position for them to be delivered via cesarean section, it will be very impossible for you to manually rotate them. And so for such fetus, you might need to do what you call a possible cesarean section for them, or cesarean section will be the ultimate in order to deliver such fetus or such babies. So that is just a brief summary of fetal presentations and which part of the fetus is coming first. Then we talk about station. I will spend a little bit time on station, and probably I'll show a picture on station. And so when it comes to station, kindly understand station. It's not difficult. So station talks about, progress of labor. We use station to describe how labor is progressing. And so station is graded from negative numbers to positive numbers. Okay, so we have positive numbers and negative, just like when you take a number plane, or when you take in school, when we're in basic school, we did number line, right? And so with number line, you have a number like this, and you have mostly the top here is the top, the positive numbers or negative. So you have your positive numbers here and you have your negative numbers here, right? But when it comes to station will have negative numbers on top and then positive numbers down. Okay. And so I am going to use this to explain station for you. And so when it comes to station, we are looking at how labor is progressing in terms of the descent, in terms of how the presenting part is engaging with the maternal pelvis. Okay, so the measurement of progress of descent in centimeters above or below the mid plane from the presenting part to the ischial spine. So when you look at, we are not going to look into anatomy here, but when you look at how the fetus descend into the maternal pelvis, you know that the fetus will be in the around the xiphoid process around, should I say, 37 weeks. And so when the fetus labor setting, it has to descend. And so the descent is where the fetus, comes down into the pelvis, right? And then from the pelvis, it comes out through the canal, and then you deliver the baby. So that kind of movement of the fetus from that high up there into the pelvis, then you'll be able to deliver the fetus, is what we call descent, right? And so we are saying that we use positive numbers and negative numbers to indicate descent, and I'll explain what both means. So when labor setting, we do our assessment. When we do our assessment, we indicate whether the presenting part has engaged with the maternal pelvis or not. Okay, during your vaginal examination, you can feel, okay, if the presenting part has engaged. If it hasn't engaged, that means that the fetus is still up there. It is yet to descend into the maternal pelvis. And so because it is still there, it hasn't descended enough. And so in that, it is either the fetus will be somewhere here. And so we use negative numbers. So you could have, let's say, -3 here, -2 here, -1. Then we have 0. Then we have 1. We have 2. We have 3. So this is how to illustrate when it comes to station. So the movement of the fetus, okay, the movement of the fetus into the pelvis, okay, is what we mean by the station. So when the fetus, let's say you do your assessment and then you have not felt the fetus in the pelvic, okay, you have not felt the presenting part, it means that the fetus is either in -1, -2, or -3. So when you are reading your question and then you see station, let's say station -3 or station -1, what it means that the fetus hasn't descended enough into the pelvis or the ischial spine, if you want, because we say that at station 0, what it means is that the fetus has now engaged with what we call the ischial spine. Okay, the fetus has now engaged with the ischial spine. So if you have a station of 0, what it means is that the fetus has descended enough, but not completely as you want it for the baby to be delivered. And so for baby to be delivered, the station must be in positive numbers. So when, let's say, you have a woman who has dilated for about 10 cm, fully dilated. For a woman who is fully dilated, you don't expect to see the station to be in negative numbers. Okay, what you want to see is that if a woman is fully dilated at 10 cm, then what it means is that the baby should be descended enough for the baby to be delivered. So for a normal labor or a normal labor progression, whilst station, is progressing, we expect cervical dilation to also correspond with station as well. So like I said, if you have a woman who is 10 cm dilated, then station should be in positive numbers. At least the baby should have engaged with the ischial spine, so that at that point in time, you know that just after the ischial spine, the baby is likely to be in the cervix and then you can easily deliver the baby. So when it comes to station, we say that negative stations are bad and then positive stations are good. So when you are reading your question, when it comes to assessment, and then labor is progressive, if it is in the latent phase, we'll go into the phases of labor very soon. If labor is in latent phase, it is normal that the station will be in negative station. But then if the labor had progressed to, let's say, the transition phase, okay, to transition. Transition means that the baby is just about to be delivered, to the transition phase. Then station should be in positive, because from transition, that means that the woman had dilated almost complete. And so the baby should have been descended enough into the positive stations for the baby to be easily, delivered. Okay, so station talks about how the baby is descending into the maternal pelvis. Okay, and I said that we use negative and positive numbers to explain that. Negative stations are not good indication if labor had progressed adequately. If it is in the latent phase of labor, and then you have station in negative, there's no problem, because latent means that the labor had just set in, and so it is yet to progress to active and then finally to transition. Okay, but from active labor to transition, you expect that the baby should have descended enough. And so when you want to grade in terms of station, you grade using the positive numbers now. Doesn't make sense in terms of station. So station 0, we have station 0, and then we have minus station and we have plus station. So station 0 means that the presenting part is at the ischial spine. I'll try to show you a picture of it so that you appreciate what I am trying to use this to represent. Then we have the negative. So the negative means that the fetus or the presenting part is above the ischial spine. And then plus station also means that the presenting part is below the ischial spine. And so for that, this baby can easily be delivered if the presenting part is below the ischial spine. Engagement, that is when the widest diameter of the presenting part has passed the ischial spine or the inlet, which corresponds to station 0. So we say engagement when you have the presenting part at station 0. That is what we mean by engagement. Now, let me use a real picture. Let me try to see if I can Google a picture so that you can appreciate what I'm trying to say. I believe that what I've said, probably you understand, but I want to use a clear picture to explain further for you to understand station. All right. So let me come. Let me see if this is what I am looking for. Very good. So this is what I am looking for. Okay. So for those who are monitoring from the screen, if you're able to monitor from the screen, this is what I am trying to explain. Okay. When it comes to station, this is what I'm trying to explain. So this is fetal station, right? So we said that this is the ischial spine here. That is the ischial spine. And when, sorry, let me clean this. I don't need this. Okay. Sorry. Okay. All right. So this is what I want. So what I want to demonstrate for you to see is this is what I have been talking about. This is station. How the presenting part is descending into the pelvis, right? And so we said that negative station means that the fetus is still high up there. And then positive station means that the fetus has descended or is descending as expected. So we say that if the station, we say station 0, station 0 is this end where you have the presenting part engaging with the ischial spine or the inlet of the pelvis. Okay, it is just about crossing what we call the inlet of the pelvis. So the moment it crosses that, then it means that it has passed through the pelvis and then it is probably in the cervix. So you can easily, deliver the baby at this point. Okay, so when labor is progressing, we want to see that in terms of station, the baby has passed the negative numbers into the positive number. At least the baby should be at 0. And when the baby is at 0, we say that the baby has finally engaged. And then when it passes 0 to the positive numbers, then the baby is, descending as expected. So you understand it better when you combine it together with what we call cervical effacement and dilation. And so, like I said, let's say if a baby or someone is in labor and the person is in stage 3, okay, in terms of labor, where the person is at the transition phase, right? And so transition means that the woman is going to dilate from is it 7 to 10, right? 10 cm. So let's say that the woman had dilated 10 cm, fully dilated. what do you expect station to be? Do you expect station to still be in the negative numbers? No. If station is still in the negative numbers, then it will be difficult for this baby to be delivered, because after 10 cm, you expect that after 10 cm, the baby should come. So at 10 cm, a baby or the fetus should be in the positive numbers for you to know that the labor is progressing very well. So when you are monitoring a client and then the client had dilated fully, but station is still in the negative numbers, what it means that you need to report to the healthcare provider, because such a baby will be difficult for you to, deliver that baby. I hope you get me. So that is the significance of what you call station. We all need to understand when it comes to um, labor and then um, delivery. Is there any question on station, fetal station, before I continue? Is there anyone who wants to add up? If you want to add up, our midwives, if you want to add up, you can add up as well. Is there anyone who wants to add up? Do you have a question on station? Okay, so we can continue, right? So let's look at signs of true labor sign and false labor sign. Okay, when you get a question and then they are asking of true labor signs, what are true labor signs? What are some of the things that a woman will present for you to know that this woman is actually in labor and it is not false labor, right? So another thing, another significance of this we are coming to learn is for you to be able to identify a patient who is likely going, into pre-labor, preterm labor, right? So for instance, if let's say you are monitoring a woman and then the woman at 33 weeks of gestation comes and complain of contractions that are regular. And then in terms of the pain, what they mostly use, of course, when it comes to the contractions and then the dilation, it is you, the nurse or the midwife, who will do that assessment. But what they mostly complain of, or what they mostly present, is the pain. And the pain is what will tell you that it is either a true labor pain the person is experiencing or is a false labor pain. Okay. So one, you look at the location of the pain. It's one. Okay. Then you look at the intensity of the pain. Two. Three, you look at, is there something that the client does that lessens the pain or that reduces the pain? For instance, change of position. If a client experiences the pain and then the client is able to manage the pain by changing position, then that is not a true labor, kind of pain. Because for true labor pain, comfort measures are not, able to kind of lessen the pain, even though you still engage the person in comfort measures, but the comfort measure will not lessen the pain. It will just help the client to cope with the pain. Okay, so one, I've made mention of the location of the pain, the intensity of the pain, and then whether something is able to kind of reduces the pain, aside probably pain medication. Okay, so one, let's look at true labor, things that will tell you that this client is actually exhibiting true labor signs, right? So first, we look at a contraction. How are the contractions? We know that for labor to set in, the uterus has to contract, and then the contraction should be regular. Okay, we'll look at how contraction should happen at each stage of labor. Okay, or during the stages of labor, we'll look at contraction proper. But when it comes to true labor sign, we say that contraction should be regular. Then, in terms of the pain that the client feels during contraction, where should that pain be located? So for true labor pain, in terms of contraction pain, it should be manifested at the back. So client will complain of back pain, and then the contractions resemble menstrual cramps in terms of the pain intensity. Very painful. You can't, when you change position, it doesn't even lessen the pain. Okay. Contractions should be regular, become stronger, last longer, and closer together. Just as you know, when labor is progressing, for the beginning, the contractions will be far apart. But as labor progresses and labor continues, you then have the contraction happening closer together. And then as it is occurring closer together, the intensity also increases. Okay, in terms of the intensity, how the client feels also increases. So contractions must be regular. Clients should be able to tell you that my contractions are occurring regularly. Let's say every 30 minutes, I am feeling the pain or I'm feeling the contraction. Every 30 minutes, I'm feeling it. And then it is progressive as well. It's not something that it happens and then I'll feel it in about 6 hours again. When it happens like that, it is not true labor sign or it's not true labor contractions. Okay. Then another thing you should also take note of is cervical dilation. Okay, or yes, cervical dilation. As labor progresses, the cervix also dilates, and then it is also progressive. And so that is why a woman will dilate from 1 cm to 10 cm when we say the woman is fully dilated. And so if someone is actually exhibiting signs of true labor, when you do your cervical assessment, the cervix should be dilating and then it should be progressive. Okay, so if let's say you do your assessment and then you get let's say 2 cm, the next time when or the next hour when you have to do your assessment, if it's actually labor, the cervix should dilate further from either 2 to 3 or 4 or 5. I hope you get me. It should not stay there forever. That means that it is not true labor. Then the fetus usually becomes engaged, as we talked about. We're using what we call station. So the fetus usually becomes engaged in the maternal pelvis or in the pelvis and begin to descend. So these are true labor signs. One, the location of the pain. We said the location of the pain is what? At the back. Okay, and then it is progressive, it causes cervical dilation and all that. Now let's look at false labor signs. So false labor signs are also known as prodromal labor, or false labor is also known as prodromal labor. Contractions are felt in the abdomen. Look at what they are saying that the contractions are felt. These are things that the NCLEX will use to try to trick him to know whether the difference between false labor and true labor. And so for true labor, we say the pain is in the what? The back. In some books, they will say lower back. Okay. But what I want you to understand is that the pain is felt or the contraction pain is felt at the back for true labor. But for false labor, the contraction pains are felt in the abdomen. Okay, and then groin. So the abdomen and groin, and maybe more annoying and than painful. And so the way clients would describe the pain, they would describe it more like it is annoying than it actually being painful. I hope you know how in terms of pain description, we all have how we describe pain. But for false labor pain, the client would describe that kind of pain as being annoying than being painful as expected for a true labor pain. Another thing is that for false labor, it does not produce cervical dilation. And so if let's say your initial assessment, you got 2 cm, after 12 hours, the patient still remains at 2 cm. After 24, the patient still remains at 2 cm. So you should definitely understand that that is not true labor sign. Okay, so for a true labor sign, there should be what we call cervical dilation, effacement, and descent. Effacement is where you have the cervix thinning in order to make way for the presenting part to easily pass through. Okay, and then contractions are also irregular. So, client will tell you that I felt contraction like 6 hours ago, and I'm now feeling one, and it is not progressive in nature. It doesn't last longer. You get it. So For contractions in forced labor, they are irregular and without progression. We said that that is Braxton-Hicks contraction, right? So if you have a client who is exhibiting this kind of contraction, it is termed as what Braxton-Hicks contraction, which are forced labor contractions. Then activities such as walking are often relieves what we call labor, relieves the pain the client is experiencing, or relieves the forced labor pain or the forced labor. So when client tells that, oh, when I experiences the contraction and I start to walk, then the contraction stops or the pain stops. Then what you should understand is that that is not actually true labor. Because for a true labor or contractions, walking shouldn't get it resolved. Okay. All right. So I have here that note that in true labor, contractions increases in duration, intensity, and then it produces cervical dilation. And then effacement are also progressive. And so effacement, we'll talk about effacement very soon. But I want you to understand effacement is also graded in percentage wise. So as labor is progressing and then the cervix is dilating from 1 to 10, the same thing we expect effacement, that is the thinning of the cervix. The cervix has to be thin enough for the head to pass through. And so that should also be progressive. And so in effacement, we grade using percentage. So you read and then they say that the woman is 80% effaced. So 80% effaced means that the woman labor is actually progressing. A woman at full dilation should have about 100% effacement. Okay. And so in forced labor, contractions are irregular. They do not produce dilation, effacement, or deesing. And so that is on labor or forced labor and true labor signs. What will help you to do that? This client is exhibiting signs of true labor and signs of forced labor. Any question, any input, any clarification here before we continue? Any addition? All right.
Amigo,
Yes, hello.
please, can you hear me?
Yeah, I can hear you, see.
Uh-huh. Please, in true labor, um, I want to know, like, the consistency. Like, how long should it take?
We'll do that
Uh,
very soon. We'll do that very soon.
okay.
We'll do that very
That's fine.
soon. Okay. So we'll go into labor very soon, and then we take each of the stages. We'll look at latent phase, we'll look at active phase, we'll look at transition. What happens at each of the stages? How are the contraction, the consistency? We'll talk about all that very soon. So if that is what you want to ask, it's there. I mean, we'll do it very soon. Okay. All right. Any further question? Any further input here? All right. So let's talk about fetal monitoring. In the NCLEX, fetal monitoring is something you cannot do away with it. So in fetal monitoring, we are coming to look at acceleration. What is acceleration? We are coming to look at, what deceleration is. We are coming to look at when we say a patient is experiencing um early deceleration, late deceleration, what do they mean? And how will you be able to even identify this on a monitor? So we'll look at it very soon. So that is what we are coming to do. So we're looking at how to identify the various fetal monitoring or the various fetal presentation in terms of fetal heart rate, okay, on a monitor in relation with maternal contraction, how you're going to identify them and the significance of it. So fetal monitoring, as we all know that we use our monitors you can use your fetoscope, but here we'll be looking at using a monitor to monitor fetal heart rate. Okay. And so the fetal monitor will display the fetal heart rate. And then the device also can monitor urethral activity. And so what happens to the fetal heart rate during maternal contraction. So the device or the monitor is able to pick maternal contraction in relation with what we call fetal heart rate. Okay, you remember when we were doing non-stress test, we said that you can use the monitor to determine what is happening in terms of during fetal activity, what is happening to the fetal heart rate. Okay. And same thing when you induce what we call contraction in contraction stress test. During contraction, what is happening to the fetal heart rate? And so you can use your monitor to also monitor urethral activity. The monitor assesses frequency, duration, and intensity of your contractions. The monitor will also assess fetal heart rate in relation to maternal contraction, right? Just like I said. What we all need to know is the normal fetal heart rate, the baseline fetal heart rate. Just like we have our heart rate when we are born, okay, we have our heart rate. And so when the fetus is also in the uterus, we should be able to know that while the fetus is in the uterus, the fetal heart rate should be between 110 to 160. If it is above 160, it is tachycardia. If it is below 110, we know it is what? Fetal bradycardia, right? And so the periodic patterns or the periodic readings that you'll be seeing a lot in your questions will be fetal bradycardia, fetal tachycardia, which I have said just not long ago that when the fetal heart rate is below 110, it is fetal bradycardia, or we say fetal bradycardia. Then, and so when it goes below 110, it should at least stay there for about 10 minutes or more for we to say that the fetus is having fetal bradycardia. So, for instance, when you are, because there are situations where the fetal heart rate can just drop and then returns back to the baseline quickly. I hope you are getting me. But if you are having a fetal, you are monitoring a fetus, and then you realize that the fetal heart rate had dropped below 110, for you to say that it is fetal bradycardia, it should last for at least 10 or more minutes. Okay. So fetal heart rate is less than 110 beats per minute for 10 minutes or longer. So not just like maybe 1 minute and then it returns. For that, we wouldn't say that it is fetal bradycardia. Probably maybe it is something small that happened, but it returned back to 8 baseline, okay, and that is normal. But if it stays there for more than 10 minutes, then it becomes an abnormality where we say that there is fetal bradycardia, right? And then fetal tachycardia, the same thing, fetal heart rate more than 160. And it should also stay for at least 10 or more minutes for us to say that that is fetal tachycardia. If you have a fetus who is having either bradycardia or tachycardia, what are some of the things that you can do? You do quick change of position of the mother. Okay, so change the position of the pregnant client. You can admit it could be that there is what we call placenta insufficiency, or the placenta is not able to deliver adequate oxygenation to the baby. And so the mother might need oxygen so that you can supplement. And so if you notice that the fetus is having either fetal bradycardia or tachycardia, you change position, mostly left lateral, which is most preferred. Then we administer oxygen. Okay, we assess client vital signs. It could be that probably there is some form of infection that could also trigger that, or maternal infection that could trigger it. So you have to also monitor your vitals, your temperature. Then you quickly inform the healthcare provider. So notify the healthcare provider as soon as possible. Okay. So the first thing you will do, if you notice that there is change in fetal heart rate, okay, and then you believe that it is either tachycardia or bradycardia, the first thing would be to change position. Okay, if the mother is not in what you call a lateral position, then before you have to also even look at what is causing it. So we'll go into it. Is it let's say uh um compression that is causing it? Okay, that is causing the fetal heart rate to drop drastically. And so that will tell you how you are going to even position the mother, okay, to relieve pressure of the cord. Is it cord compression that is causing the fetal heart rate to drop? And so in that instant, you might even have to, position the mother in Tredelumbeck, as we all know, so that it will shift the presenting part of the cord so that you can reestablish circulation. So what is actually causing it will also help you to know how you're going to position your mother, okay, or the mother. So these are what you do when you are having tachycardia or fetal tachycardia, and then or fetal bradycardia. Any question on fetal tachycardia and bradycardia you want to ask before we talk about viability and what viability means, as well as acceleration?
I mean,
Yes, madam.
good afternoon indeed.
Good afternoon.
Uh, I wanted to ask about management of the fetal tachycardia or bradycardia. Do we
Mm.
give IV fluids?
Do you
What's the
give
word? IV fluids.
IV fluids?
Fluids, yeah.
Yes. Yes. So yes, you can give IV fluids. Okay. That's why I said we are coming to take them one after the other. So look at in what case you can give your IV fluids. Okay. So I'm saying that you can, yes, you can administer your IV fluids. Okay. For instance, if you are having someone, so if you are having someone with fetal tachycardia, okay, of course you can give your IV fluids. You can mostly normal saline, not any and then ringers, either normal saline or ringers. So we say that you give your bolus IV fluids, okay, at the start. Once you change position, you administer oxygen and all that. So IV fluids can also be given as well. All right. Let's look at viability. So viability, it's an English word, right? So fluctuation in something. Okay, so when you have the fetal heart rate fluctuating, okay, fetal heart rate, the baseline fetal heart rate fluctuating, which is normal, that you don't expect the fetal heart rate to remain constant forever, right? Just like when you are there, you don't expect your heart rate to remain constant forever. There are times you walk, and when you walk, your heart rate goes up. When you sit and you are rested, your heart rate kind of drops a little, right? So the same thing, when the fetus is in the uterus, it engages with the mother or it moves. Okay, so fetal movement and all that causes variation in the fetal heart rate or fluctuation in the fetal heart rate. So you could have someone with, let's say, a baseline fetal heart rate of 120. At the point you check, it is 130. At the point you check, it is around 115 or 110. What you need to understand that it should not go above the normal and should not go below the normal. And we said how long it shouldn't stay or it should stay for us to say it is an abnormality. You can have a situation where you are not detecting fetal heart rate, or there is a situation where there is no variation, or fetal heart rate stays constant. When you notice that, it can either be reassuring or non-reassuring, right? And so ideally, when you monitor the fetus and you realize that the fetal heart rate has remained constant for a very long time, it is not good. It is non-reassuring. So absent or undetected viability is considered non-reassuring. So non-reassuring means that it is not a good indication, because ideally you don't expect that the fetal heart rate should stay the same for over 2 hours or over 1 hour. Even after 30 minutes, it's still a concern, because it is said that if the fetus is asleep, the fetus will not be asleep for more than 30 minutes. After 30 minutes, the fetus should be awake. You remember when we're doing what we call non-stress test, we said that when you don't get that kind of acceleration, you continue your monitoring for an additional 20 minutes to get 40 minutes. And so after 30 minutes, if actually the fetus is asleep, and that is why the fetal heart rate has stayed the same, after 30 minutes, there should be fetal movement that will cause the fetal heart rate to increase. So absent or undetected variability is considered non-reassuring. Decreased variability can result from fetal hypoxia, acidosis, or certain medication. And so instances where you can have the fetal heart rate remaining the same or remaining constant could be as a result of medication probably you have given to the mother that had crossed the placenta barrier and affected what we call the fetus. Or it could be as a result of fetal acidosis or hypoxia. Okay. And so these are situations where you can have decreased variability. That means that there is little change in fetal heart rate, which has stayed for a very long time, which is not a good indication. You can have a temporal decrease. So the temporal decrease is where I was saying that when the fetus is asleep, for that one, because the fetus is asleep, there's no activity. So you expect the fetal heart rate not to increase or not to change in terms of, figures. And so for a fetus that is asleep, the fetal heart rates can remain there or can remain at the baseline for some time. And for that, it should not go beyond 30 minutes. So a temporal decrease in viability can occur when the fetus is in a sleep state. A sleep state do not usually last longer than 30 minutes. And so after 30 minutes, if there is a decreased viability, you quickly have to inform the healthcare provider, because it's not a good indication. Okay, so that is viability. So we say viability is where you have a fluctuation. At least the fetal heart rate, while the fetus is engaging, is moving, the fetal heart rate should be swinging. At least it should be moving, it goes up. We said at least 15 beats per minute. Okay, then it will return to the baseline, or it can decrease a little bit. Okay, then it returns back to the baseline. That is the kind of viability of fluctuation that we want to see for a fetus who is doing very well and a fetus without any form of issue. Okay. Then we have something we call an acceleration. Acceleration is where you have an increase in fetal heart rate. And so remember, I said that viability is something that you want to see. Absent viability is non-reassuring. So when you are reading your question and they are asking of which of the following fetal heart rate or fetal heart rate monitoring would require you to report to the healthcare provider, and you have absent viability, remember that it's a question mark, because absent viability is not something you want to see. Okay, you want to see viability. That is fluctuation in the fetal heart rate you want to see. The next thing you want to see is acceleration. So we say that acceleration is always good. Acceleration is where you have a brief temporary increase in the fetal heart rate of at least 15 beats per minute, lasting for 15 seconds. Just if you remember this in non-stress tests, I made mention of it. Those of you who were here when we started. The recordings are there. It's even on our YouTube. So those who just join us, you can get the previous class to also make use of it. Okay. Sometimes I used to make reference to what I've said previously. So for acceleration is where you have the fetal heart rate increasing to at least 15 beats per minute above the baseline, and then lasting for what, 15 seconds. So let's say you have a fetus, the baseline fetal heart rate is 20 minutes, 120 beats per minute, 120. In terms of acceleration, at least we want to see that during fetal activity, the fetal heart rate increases to at least 135. And then when it gets there, it gets to the 135, it should stay there for at least 15 seconds before it returns back to the baseline. And so if you have any fetus where you are doing your monitoring and you are picking this up, it is called acceleration, which is good, which is a good indication, or which is a good sign. There's no need to report to the healthcare provider. So in your case study question, when you are reading and an assessment, you see an acceleration, pick it at acceleration is something that is good. And then you want to see when you are doing your fetal monitoring. So usually a reassuring sign, it indicates that the fetus is responsive and then non-acidotic as well. Usually occur with fetal movement, as I said. It may be non-periodic. It has no relation with contraction. So it can occur at any point in time, okay, especially during fetal activity. And so it doesn't actually have a relationship with what we call contraction, or it shouldn't happen during maternal contraction, okay. Or it can sometimes also happen with what we call contraction. So you don't necessarily have to see this during contraction. However, during contraction, you can see this form of acceleration, which is good. So it may occur with uterine contraction during vaginal examination or some form of mild cord compression, or when the fetus is in a breech position. You can see acceleration in these situations. But generally, when you are reading your question and you come across acceleration or fetal acceleration, just note that it is a reassuring sign. It is not something that you will need to what we call report on. Any question on acceleration? Any input on acceleration you want to ask?
Hello, sir.
Yes, Adam.
Please, if I got it right, which means the acceleration is a good sign, but the
Yes,
variability is a good sign.
is that viability
Like it's not a good sign.
is a good sign.
Okay. Please, I
I
didn't
said
get the
I said
explanation well.
I said viability is a good sign because you don't want the feeder. What the meaning of viability is, that kind of change or that kind of constant variation, okay, in the fetal heart rate is what we call viability. And so for a fetus that is doing well, you want to see what we call viability. And so acceleration could be a part of viability because acceleration is a change in fetal heart rate. And we are saying that viability is also that up and down movement of the fetal heart rate. But even with that, it has to remain within what we call the normal range. I hope you are getting me. So what it means is that acceleration is a form of variation, or viability is a form of viability, but this viability only, happens when there is an increase in the fetal heart rate. I hope you are getting me. So viability is good. You want to see that kind of up and down movement in the fetal heart rate. You don't want to see the fetal heart rate staying the same forever. So I said that what is not good is absent viability or undetected viability. That is what I've indicated here. So absent or undetected viability is considered non-reassuring. But if you have your fetus where there is viability, then it indicates that everything is fine. The fetal heart rate, it's swinging, or that there's that variation, which is fine, or fluctuation, which is good.
Okay, thank you.
All right. Any other question? All right. Let's look at acceleration. Acceleration. No, early. I've talked about acceleration. Early D cell. Early D cell. Early D cell. Is early D cell good or bad? when you are monitoring or you are reading your question and you come across early decel or early deceleration, what causes the fetal heart rate to drop, or what causes the fetus to experience early deceleration? So early deceleration, I said that deceleration is an English word, which means that a drop in something or something coming down. Well, when you are descending from a stairs, it means that you are coming down. Okay, so early deceleration are decreases in fetal heart rate below baseline. Remember, listen to the definition. Decrease in fetal heart rate below baseline. The rate at the lowest point of deceleration usually remains greater than 100 beats per minute. Right? Remember that when we spoke about, or when I spoke about bradycardia, I said that bradycardia is where you have the fetal heart rate dropping below 110, staying there for at least 10 minutes. That is where you can say it is accelerated. It is this, it is bradycardia. And so in early deceleration, you have the fetal heart rate dropping, okay, but it will not go below 100 beats per minute. It will usually be about 100 beats per minute. And then when it happens, it doesn't also stay for long, and then it will return back to the baseline. So we'll look at what causes this to happen to the fetus. So early deceleration occurs during contractions as the fetal head is pressed against the maternal pelvis or against the pelvis or the soft tissues such as the cervix and returns to the baseline by the end of contraction. So what causes the fetus to experience early deceleration is that during labor or during labor, when labor is progressing, you have the presenting part engaging with the maternal pelvis. And so at the point when there is contraction and then the presenting part is also pressed or is also like kind of pressed against the maternal pelvis and then the soft tissues such as the cervix, you have the fetal heart rate dropping. And so that is what we call early deceleration. So early deceleration happens when you have the presenting part engaging with the maternal pelvis when contractions are happening. And then the fetal heart rate will quickly returns back to the baseline after the contraction has ended. So I said that one, early deceleration happens when you have the presenting part engaging with the soft tissues and that of the maternal pelvis. That's when it is pressed against them. Then it happens during contractions. So it happens together with contractions where you have the fetal heart rate dropping. And then the fetal heart rate quickly returns back, or it quickly recovers back to the baseline after the contraction has ended. The tracing, I'll show you how it looks like on the monitor. The tracing show a uniform shape and monitor an image, okay, of uterine contraction. So it happens together with contraction. So I'll show you how you'll be able to identify. You will see that during maternal contractions, then there is a drop. At any time, at any point in time, there is maternal contraction. Sorry, yes, there's contraction. That's the uterus are contracting, then the drop will happen. The drop in fetal heart rate will happen. And then the moment contractions ends, it returns back to the baseline. That is how, so when you look on it on the monitor, it has that kind of uniform appearance kind of thing. So let me show you this. So it will have something like this. So you can have, let's say down here being contractions, and then up here being the heart rate. And so whenever there is contraction, you see that there is a drop. Whenever there is contraction, there is a drop. Whenever there is contraction, there is a drop. So it will have a uniform appearance on what you call the monitor. Okay. Early deceleration are not associated with fetal compromise and requires no intervention. So please, when you are reading your question and you come across early deceleration, continue your monitoring. No action. There's no need to report to the healthcare provider because it is a good indication. It means that the fetus is descending as expected because we said that it happens when the fetus has engaged, right, has engaged with the maternal pelvis and the soft tissues. So that means that the fetus is coming. That is why you see that kind of, sharp drop when there's contraction and then it returns back to the baseline. Okay, so early deceleration is a good outcome. You don't need to report. You don't need to take any action. Continue to monitor. So in your question, when you get a question and we say that you are doing fetal monitoring, you see or you notice early deceleration, what will be your priority intervention? A, continue to monitor. B, report to the healthcare provider. C, administer normal saline. D, administer or let's say change of position, or they say that administer oxygen. Understand that early deceleration is a good indication. It doesn't require any activity or any action. You continue your monitoring. Any question on early deceleration? Any question on early deceleration? Or any input on early deceleration? Early deceleration. I hope we understand what early deceleration is. And the
But
action.
actually,
Yes, Madam Abba, continue.
please, this one there, I'm sorry, I beg. With the late deceleration, what
I'm here
caused?
to talk. I am here to talk about late decel.
Oh, okay, all right. I was away for a while.
I'm here to talk about late decel. Right.
All right, thank you so much.
All right. Any question on early decel? Early decel. Before we speak on late decel. All right. So let's look at late decel. What our sister wanted to know. Okay. So late decel are non-reassuring. That is the first thing I want to put in the back of your mind. That one, late deceleration are not reassuring. They are non-reassuring. They are bad indication. They are things that you need to report to the healthcare provider. They are monitoring, or they are things that you need to take action when you are doing your monitoring and you see that on the monitor you pick up late deceleration. It is something that you need to report on. So the name is late deceleration. Early deceleration happens together with contraction. The drop in fetal heart rate happens with contraction. So we see that it is early. But then late deceleration, late decel, the drop in fetal heart rate happens after contractions. After the contraction has ended, that is when you see that there is a sharp drop in fetal heart rate. And the drop in fetal heart rate goes below 100. Remember, we said that with early decel, the fetal heart rate would definitely stay above 100 and it will never go below 100. But for late decel, the fetal heart rate goes below 100 beats per minute. And it happens after contractions has ended. That is when you see the fetal heart rate dropping, right? And so first, I said that it is non-reassuring. It is something that requires action. And it happened, or it indicates that there is impaired placenta exchange or uteroplacenta insufficiency. So what it means is that the placenta is not functioning adequately in terms of its function, in terms of delivery of blood, oxygen, and other things to the fetus as expected. So we say that late deceleration is caused by placenta insufficiency or uteroplacenta insufficiency. Okay, the pattern looks similar like early decel, but begins well after contractions begins and then returns to the baseline after contractions end. I'll show you the picture so you can distinguish between early decel and late decel, right? The degree of decline in the baseline fetal heart rate is not related to the amount of uteroplacenta insufficiency. And so here, I said that in late deceleration, the fetal heart rate in terms of the drop, it drops below 100. So you can have the fetal heart rate dropping from the baseline to about 90 to 80 and all that. Okay. And then interventions for late decel will include, immediately improving placenta blood. Okay, so this is where you have to administer your IV fluids, okay, to improve on blood supply, okay, or to improve on placenta supply, okay, to the baby. And so you have to administer IV fluids quickly. You change position. You also administer oxygen. You inform your healthcare provider as well. So I have the intervention for all the non-reassuring boxed together. And so we'll talk about that very quickly. And so that is on late decel. And so for Abba who wanted to ask on late decel, I don't know whether what you wanted to ask, I've made mention of it. If I haven't talked about it, you can bring it up so that we look into it together.
Okay, but Saki, please, my confusion is with the late diesel. So I surely based on the fetal heart rate that with that one it decreases from 100 to maybe 90 or 80. Is that
Yes,
all?
one.
And that's please, sir.
One, I am giving you the what you need to concentrate on when it comes to late decel. So one, late decel. I said that the drop, it mostly goes below 100 beats per minute. Two, the cause of late deceleration is as a result of placenta insufficiency. That is another thing you need to take note of. Then the shape of it or the appearance, that one I'm here to show you. So I will show you that very soon. Okay. And it also doesn't have a uniform appearance. Okay. Or as compared, it looks similar. It looks similar. Okay. As compared to the LED cell. But there's a difference. I'll show you when I'm using the image to do that. But what I want you to pay attention to here in late decel is that I said the cause of it is 1. And the drop, we said that in early, it will definitely stay above 100. But in late, it goes below 100 beats per minute. And then the intervention of it, we said that in early decel, we don't do anything. We continue to monitor. That is early decel. But in late deceleration, you can't continue to monitor. You need to take action. You need to position the mother in the left lateral. You need to administer oxygen. You might need to, if the client is taking oxytocin or pitocin, you need to stop the pitocin or the oxytocin. Then you need to administer your IV fluids. So intervention that will enhance placenta blood or will improve placenta blood supply to the fetus. The question will not measure. NCLEX is not just the way you are imagining in that. That is not how the NCLEX work, okay? You will not get a question where it will just through deceleration. Never. It will be specific because it will never say deceleration. Okay. Without adding whether it is early or late, it will never say that. Okay. So let's not think that way. Okay. It will never put you in that dilemma. That is a dilemma. All right. It's good. Sometimes sometimes we do ask ourselves questions when we are learning. That's very good. Any other inputs here? Any other question? So I don't know whether Madam Abba, you still have any question on what you wanted to know. What you need to know about late diesel is what I made mention of. I don't know
Hello.
whether there is something that you still want to ask.
No, I'm okay, please. Thank you.
You are okay.
Yes, please.
Okay.
Thank you so much.
You're welcome. Any question before we talk about viable diesel? variable D cell. Variable D cell. Anytime I'm doing this and I get here, I say that among all the non-reassuring or among all the bad ones, this is what you don't want to see at all. Variable D cell. It is also a drop, or it also talks about a drop in fetal heart rate. But this drop is a very deep one, or is a very sharp one. A very deep. It can go as low as 70 beats per minute to 60 beats per minute. Okay. The cause of it is what you need to understand so that you can distinguish between it and that of late D cell, right? Because they are all having D cell, D cell, D cell. So variable D cell, it's one, it is non-reassuring. So let's put that at the back of our mind. The cause of it is any condition where there is a restriction of flow through the umbilical cord. So anything that restricts flow or anything that compresses the umbilical cord causes variable D cell or can cause variable D cell. And so, for example, when you are delivering the baby, okay, when you are doing your delivery, and then you have the umbilical, so we call something called the cord, we say cord has come out first, right? Or we call something cord compression. So cord compression means that the umbilical cord has come in between the presenting part and that of the maternal cervix. Also, the cervix, yes. So the cord, that's the umbilical cord, has come in between the cervix and that of the presenting part. What will then happen is that the presenting part will exert pressure on the cord, or it will press on the cord, and now nothing can flow through what you call the cord again. And so at the end of the day, there is what you call a restriction in flow, or there's a restricted flow through the umbilical cord. And that causes the fetal heart rate to drop drastically. So variable deceleration are caused by conditions that restrict flow through the umbilical cord. And one example of condition where you can have, or a situation where you can have cord compression or the umbilical cord being pressed on or being compressed, is when you have the umbilical cord coming in between the presenting part and that of the cervix. Okay. Variable D cell do not have a uniform appearance as compared to early and late D cell. So on your monitor, variable D cell does not have a uniform appearance. It happens anyhow, haphazardly on the monitor. It has no relation with maternal contractions. Okay, it can happen just as we said. We said it happens when there is a condition where there's a restriction with the flow through the cord. The shape, duration, and degree of decline below the baseline are variable. This falls and rises abruptly. Okay, it falls and rises anyhow with the onset and then with onset and relief of cord compression. So you can only resolve variable D cell after you have relieved the cord compression. So what it means is that if it is the presenting part that is exerting pressure on the cord, the only thing that you can do to resolve variable D cell is to take the presenting part off the cord. And so in management, what we do is that we say you wear a sterile glove, then you lift the presenting part off the cord so that you can establish flow. So during monitoring, when you pick what you call variable D cell, quickly do assessment. Check what you call the cervix. Is the cord out first? If the cord is out first, then definitely the presenting part is going to exert pressure on the cord. So what you quickly have to do is to wear glove and then you lift the presenting part off the cord. Another thing you can also do is by positioning of the mother. And so you position the mother in what we call a Trendelenburg position. So when you put the woman in a Trendelenburg, what happens? You lift the legs, right, the lower extremities, and so when you lift the legs, it pushes the presenting part back. Okay, and so when it pushes the presenting part back, it then releases the pressure on the cord, and so you can have flow through the cord being established. So the only solution to to variable decel is to make sure that whatever is being exerted on the umbilical cord is taken off, so that it can re-establish flow. I hope you get me. Then let's continue. If you have a question, when I'm done, you can bring it up. Okay. So the baseline rate and variability are considered when evaluating what we call variable decel, right? And then variable decel are significant when fetal heart rate repeatedly decline to less than 70 beats per minute and persist at the level for at least 60 seconds before returning to the baseline. So what it means is that you can have someone experiencing variable decel, or a fetus experiencing variable decel, and then the fetal heart rate can drop up to 70 beats per minute and then remain there for a full 1 minute. That is 60 seconds, and that is very bad. Okay, that will require you to take immediate action. So what are the action if you are monitoring a client and the client is experiencing variable decel? First, check if the person is taking oxytocin. If the person is on oxytocin, the first thing you have to do is to stop the oxytocin. But if there is no oxytocin ongoing, you have to change the position of the pregnant client. Then you administer oxygen. Okay. Then assess the client's vital signs. You then notify the healthcare provider. So we can also assist with what we call amnio infusion, that is intrauterine instillation of warm saline to decrease compression on the umbilical cord if that is prescribed. So that is one thing you can also do to kind of lessen the pressure on the cord. So I said that the ultimate to resolve this is by relieving the pressure on the cord. But these are other interventions you can take to also kind of manage variable decel. So one on variable decel, I said the cause of it is when there's cord compression. That is one thing the first thing you have to put at the back of your mind. When I ask the cause of variable decel, you should be able to tell me cord compression. Then intervention. Okay, first, check if there is oxytocin. If there's oxytocin, you stop the oxytocin first. Then you change position. So the change of position is what I said. So in terms of change position, they make mention of the Trendelenburg position, and then you can also do lateral. Okay, it can also help to relieve what you call the pressure from the cord as well. You can also lift the presenting part from the cord, right? And then you administer oxygen. You do your assessment, that is vital signs assessment, and then you also inform the healthcare provider. Any question, any input on variable decel? On variable decel? Is there anyone with a question on variable decel? Actions you need to take for variable decel? Cause of variable decel? Yes.
Hello, Flamingo.
Madam.
My own is not a question, but I think
Mhm.
I had an experience with the intrauterine fluid installation. Uh-huh. When I went into labor, they said that I was having fetal deceleration, but they didn't state whether it's early or late. They just
Okay.
say it's fetal deceleration. So when I ruptured, my membranes ruptured, and then they
Yes.
saw it was meconium stained. So the RN said they will have to do the intrauterine fluid resuscitation. So they inserted a catheter, and then they instilled the normal saline, warm normal saline inside. So it's when we were learning this, I said, "Oh, I experienced this."
Oh, okay. So
Oh,
you
it's nice. It's nice. It's nice.
okay. So so experience has come
I
in
won't
here.
forget this when I see
You
it.
won't forget it anywhere, right? Okay, that's good. All right. So that is, she has experienced the practicality of, the amnio infusion, okay, where they is still, fluid into the intrauterine or the intrauterine installation of warm saline. It decreases compression, okay, to resolve deceleration. That is variable deceleration. Then probably maybe you were experiencing variable deceleration. And another thing that also causes variable deceleration is when you have when the amniotic fluid is coming. So what happened is that the amniotic fluid also sweeps the cord. Okay, so the amniotic fluid also sweeps the cord. So you can have the cord coming out as a result of the amniotic fluid that had broken and then it's coming out. So it sweeps the cord alongside, and then the cord will then come out first. It's just like when a wire is there and you pour water on the wire. What happens? You realize that the water will kind of pull the wire alongside. Okay, and so that is what happens when amniotic fluid, what amniotic fluid can do, okay, in terms of cord compression or in terms of variable decel. So then probably maybe it was variable decel that you were experiencing. Okay. All right. So thank you for that addition. Okay. Any inputs here as well? Any question before we try looking at?
Yeah, please, Master, I have a question.
Yes, senior. Senior, your
I
name?
want.
I see Techno.
Oh, this is Wilson.
Wilson. Okay. Wilson, you've changed today. You're not using your name. Okay. Because I used to use Mr.
I,
Wilson. I used to see
yeah, I
Wilson.
don't know. I don't know how it came as that.
Oh, okay.
I want to find out what would be the first thing a nurse would do in variable deceleration.
Variable diesel. So
Yes, what would be the
I said
first
that.
thing that a nurse would do?
I said that the first
Okay.
thing you do is to look at what. So I usually want a full question. And so, for instance, if the client is on
Okay.
oxytocin,
Okay.
okay.
So let me come in. If they ask you, let's say A, stop
Uh-huh,
oxytocin. B,
uh-huh,
reposition the
uh-huh,
client.
uh-huh,
C,
uh-huh.
report or call the healthcare provider.
Mhm, mhm. So
Which
meaning
one will
that,
you?
so
Mhm.
meaning that the client had oxytocin on whilst
Yes.
experiencing the variable diesel. The first
Yes.
thing that you do is to stop the oxytocin.
Okay.
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 Okay. But if they ask that what would be your highest priority is the change of position.
Oh, okay.
So the difference here is that the first thing would be to stop the oxytocin. But the highest priority, if you can do anything, okay, at that moment to save the woman, will be the change of position, which can help lift the presenting parts. Okay.
Okay.
And that alone, I said that alone will be enough to kind of resolve the healthcare, to kind of resolve the situation. Then you inform the healthcare provider. Are you getting the point I'm making here?
Yes, please.
Because it is something that is pressing on what you call the cord, leading that to happen. And it's mostly when you do change of position, it helps to lift, or it helps to, if it is, yes, it helps to shift whatever is pressing on the cord back, and that will resolve, that kind of pressure on the cord. But if it's what you do first, when you have oxytocin on, then it is oxytocin first before you change position, and then the healthcare provider will come in.
Okay. But if they also ask it this way, let's say a patient walks in and pay your examination, you
Uh-huh.
have realized that the patient is having there's a variable deceleration. What would the nurse do first?
Patient walked in.
Yes.
A patient who is experiencing variable diesel will never walk in.
Oh, okay. Okay. Let's say per your assessment, and you found that there's a variable deceleration. What will you do? Oxytocin is not on. So will you call the healthcare provider first, or
No, so you change position first
you
before.
change
So in
position?
that
Okay.
instance, it's change of position first.
All right.
It's before you inform the healthcare provider.
All
So
right.
it's
Thank you,
something
sir.
you can do to salvage the situation before healthcare provider is informed.
Brother Mingo,
Yes,
please, I
madam.
want to ask, what if there is oxytocin in the options to choose? There is and stop oxytocin, and turn patient, and
I think
which
I I think I answered that first, that if
Yes.
there is
Yes.
if there is oxytocin on and they
mm,
ask what is the first thing you do, is to turn off the oxytocin. Okay. It's just like infusion. You stop the infusion, then turning the patient will take some time, because you cannot just come and then quickly turn your patient. But when it comes to, I mean, what is it?
Stopping
Stopping the
the process.
infusion. It is just, I mean, a click of an eye, you stop it. I hope you get the point I'm making. So if they are asking of there's oxytocin on, and the question is, what is the first thing you do? Well, if the client is on oxytocin, the first thing you do is to stop the oxytocin before you change position.
Mm. Okay.
That is
Thank you very
that is
much.
what I said first when
Mm.
Mr. Wilson asked the question. So I don't know whether you were off then or you were actually not following. Are you getting the point I'm making here? The one who asked the question.
yes, I get the point.
Yes, Sally. All right. Any question? Any other question? Okay, so let's go. Let's look at the strips. Let's quickly just look at the strips. I think it just some few times I met some Q1 questions where they were asking about the strips. So when you look at the fetal monitor, okay, or if you want to do your monitoring on the monitor, these are what you see. So the top one is what is your fetal heart rate, okay? And then the bottom is the maternal contractions, right? So here we know that fetal heart rate, we are starting from 60 to 180, right? And then we said that we have baseline. So the baseline is the fetal heart rate, his or her baseline, just like we have our baseline heart rate. And so let's say the baseline fetal heart rate for this, it's around, let's say 130, somewhere here. You can say about 130. That is the baseline, right? And first one, we said that we talk about early deceleration. What did we say? We said early deceleration happens with when you have head compression. That is, if the head is coming, right? That is, if the head is engaging with the maternal pelvis, which is a good indication. And we said it has a uniform appearance on the monitor. We said that the drop in the fetal heart rate happens at the same time when contractions are happening, right? And then we said that the fetal heart rate will usually stay above 100 beats per minute. These are the things I said when I was talking about early diesel, if you remember. So let's look at what you're likely going to see. From here, you can Google and you get maybe a better strip or a better strip so that you can understand it very well. So on the monitor, okay, you see something like this. So we say it happens together with contraction. Whenever contractions are happening, so this is contraction here. Okay, so this is contraction happening here. You see, this is contraction. So here is contraction. This is the peaking of contraction. Then the contractions start to drop here. And so we are saying that a drop in fetal heart rate that happens together with maternal contraction. So you see that there is a drop here. Okay. There is a drop here. There is a drop here. Then there is contractions are happening here. There's another drop here. Contractions are happening here. There's another drop here. So you realize that the drop is just something small. And then we said it usually stays above 100 beats per minute. So this is 100. And so it doesn't go below 100 beats per minute. and that is LED cell. You see that it has a uniform appearance. It goes together with maternal contractions. Okay, so that is how LED cell will be seen on the monitor. No action on LED cell, continue to monitor. Then we take variable. So this is my variable. That's why I said that you can Google and get a better one. What I'm using here, it looks like it has a uniform appearance, but it doesn't. Okay. So the actual thing should have been that this is my strip. I think I have to change it for us to get a very better view. One, you have to first look at the drop. We can still use it. We said that variable decel happens when there is cord compression, okay? And we said that the drop in fetal heart rate can go as low as 70 beats per minute. So now let's look at this. This is contractions happening here. We say it could be periodic. It cannot, sometimes it doesn't go with what we call contractions. It can happen anyhow, haphazardly, unperiodically with what we call maternal contractions. But when you look at the fetal heart rate, what do you see? You realize that the fetal heart rate has dropped to somewhere around 60. So this is 60. And then you have here. So this is 60 here. So you realize that at this point, the fetal heart rate dropped as low as 60 beats per minute. Over here, it has also dropped. This is around 70. Here, around 60. Okay, so you realize that if you look on a proper monitor, or if you get a proper one, you realize that the drop in the fetal heart rate happens anyhow. So you can also have another drop in fetal heart rate happening here, another one also happening here, and then it doesn't have a uniform appearance on the monitor. When I'm done, I'll Google another one so that we can use that one as well. But for a variable decel one, the drop is very sharp. It goes below as low as 70, 60 beats per minute. Okay, and it has no uniform appearance, and it's not periodic as compared to the other one. Okay, and it doesn't usually also go together with maternal contractions. So when you look at the drop, first look at the drop, how the drop is, then you look at the nature of it. Okay, it should not go together with what we call maternal contractions. And then we've spoken about interventions for variable decel. That is what we just did before we got to this slide, right? So we said that you change position, you stop pitocin or oxytocin, you administer IV fluids, you can also oxygen and all that. Then we talk about late decel. So this is late decel. So I made mention that late deceleration has a uniform appearance, and the drop in the fetal heart rate happens after contraction has ended, right? After contractions has ended, then you have the fetal heart rate dropping, right? So let's look at this. Let's take this as an example. So this is late decel. So over here, as usual, we have our contractions here, then we have our fetal heart rate on top, right? So look at this, look at here. This is what you have to concentrate on. This is the fetal heart rate dropping. When is it dropping? It is dropping just at the point, or the dropping starts at the point when fetal contraction have peaked, right? So when contraction have peaked, that is when you start seeing the fetal heart rate dropping. And so at the time contraction will end, the fetal heart rate had dropped. And the drop it also goes below 100. But we said that it is not as deep as late decel. Okay. And it will usually go below 100 sometimes. Okay. And then before it returns back to baseline. We said that the cause of late decel is what? Uteroplacental insufficiency. So your interventions are to ensure that you have improved placenta blood flow, right? Or placenta blood supply. Okay. So you have contractions happening, then fetal heart rate dropping just after a contraction had peaked and then it's ending. That is where you have the drop in the fetal heart rate happening. Then you take another one here. So when you take this one, how are you seeing? You are seeing that there is a drop here. Sorry, there is a contraction happening here. And then when the contraction had peaked, that is when you see that the fetal heart rate has started dropping. And then by the time contractions ends, the fetal heart rate has dropped drastically, or it has dropped. And then another one happening here. So you realize that it also has a uniform appearance when you look on it, or when you look at it on a monitor. It has a uniform appearance. So this is how late this cell will appear on your fetal monitor. On your fetal monitor. We've looked at its intervention in our previous slide. Then this is acceleration. So acceleration is normal. We said acceleration is normal, no action, continue to monitor, right? And so we said acceleration is where you have an increase in fetal heart rate, usually during fetal activity or during contractions, right? So here you see that contractions happening here, and then fetal heart rate increasing here. The same thing, contraction happening here, and then fetal heart rate also increasing. And then the same thing happening somewhere here. And then you have fetal heart rate also increasing. Okay, so you see it also has a uniform appearance on the monitor. Okay, yes. So we said that the rise, at least the increase should be at least 15 beats per minute. At least it can go about 15 beats, right? But it should be at least, for you to know that this is a good acceleration. The increase in fetal heart rate should be at least 15 beats per minute, lasting for 15 seconds before it returns back to the baseline. So acceleration looks like this on the monitor, and you don't need any action on acceleration. Continue your monitoring. No action. No need to inform healthcare provider. It indicates that the fetus is strong. The fetus is doing well. Then we talk about variability. Remember, we said variability is where you have that fluctuation. So we want to see fluctuation in the fetal heart rate for a normal fetus without any issue, without any hypoxia or hypoxemia or acidosis or any kind of medication affecting the fetus. We want to see that kind of, swing in the fetal heart rate. So we said variability is something that we want to see, but how do we want that variability to be? Is it, a marked one, or is it a moderate one? We will look at it. So we said that absent variability is where you have the fetal, or decreased variability or absent is where you have the fetal heart rate remaining the same for a very long time, more than 30 minutes. Okay, and that is a bad indication. So for instance, when you take this one, you realize that this fetal heart rate had remained around, if you want, around 120 or so, 130 throughout the period, which is not good. So when you are doing your monitoring and you see this kind of line, so we say that if it was EKG, what would have been it? What would have been it? Oh, um, um,
Assistant.
Asystor, very good.
Yeah.
So if it was EKG, you would have said Asystor, right? And Asystor is not good. It means that the patient, if it was EKGs and you are seeing Asystor, it means the patient is gone, right? Your patient is almost going cardiac arrest. Patient is no, that kind of thing. So same thing in fetal heart rate monitoring. When you see a straight line, or when you see that the fetal heart rate had remained constant for a very long time on your monitor, it's not a good indication. That is absent variability, which is bad. You need to report to the healthcare provider. Okay. Then we have marked variability. So marked variability, you see how it goes. So marked variability is when you have that up and down movement, up and down. It could mean two things. It could be that it is either a good indication or it's a bad indication. So a bad indication is where there is fetal distress. So in fetal distress, you're likely going to get marked viability, right? That up and down swinging in the fetal heart rate. Or it could also be a good one, especially when there is, maybe fetal activity and the fetus is moving and up and down. When there is a marked fetal activity and it's a good fetal activity, there's going to be marked viability. Okay, so marked viability could be two things. When you get it, do your assessments again to be sure that it is not fetal distress, or it's not it's not a bad thing before you then conclude on what to do. Okay, so marked can be either good or bad depending on what is triggering it or what is causing it. Okay, then we have moderate. So moderate is good. So in terms of viability, we want to see moderate. Okay, once a while you see, an increase, then you see a drop, you see increase, you see a drop, you see increase, you see a drop. That kind of, moderate up and down movement of the fetal heart rate is what we want to see in viability. And so that is that on what you call the various fetal heart rate tracings that we need to know, and which one is good and which one is bad. And so in summary here, non-reassuring fetal heart rate patterns that you need to report on. We've talked of fetal bradycardia, we've talked of fetal tachycardia, we've talked of late D cell, and then prolonged D cells. That is when the drop in the fetal heart rate is staying forever. And then when you also have hyperuterine activity, that is contractions happening closer together. And so we'll talk about that, either tomorrow. How when contraction happen, how long contraction should happen, okay, and then how long it should last for. So if you have someone who is having contraction every 1 minute, it is not good. That is hyperuterine contraction or hypertonic uterine activity. It's not good. So at least even at transition, contraction should be happening every every 2 to 3 minutes. Okay, that is when you should be having. If you are having contraction every 1 minute, it's not normal. That is hypertonic uterine activity that needs to be reported. Then decrease or absent viability is not good. And then viable D cell is also not good. It mostly becomes worse when it drops as low as 70 beats per minute, lasting forever. This one here, everybody who is preparing for NCLEX should be able to keep this, should I say, mnemonic on my screen, or is it abbreviation, or however you put it? Okay, you should be able to keep this. And it is a summary of all that I have said today. This summarizes everything I have said today. So fetal heart rate patterns and their causes. So we said that V chop. So you see V chop in your books. You see V chop. So the V are the pattern, the fetal heart rate patterns, and the chop is the cause, or maybe the actions you need to take. So we said the V is the first V. The V is viable D cell, and the cause of viable D cell, we said what? Cord compression. And then LED cell, we said LED cell is caused by what? Head compression, which is good, no action. Then acceleration is when you have what? Acceleration is where you are having the up and down movement, right? Or the upward movement the increase in fetal heart rate during fetal activity. Okay. And so it says that okay, right? So acceleration is also what? Okay. So the O in chop is what? Okay, which correspond with acceleration. It means okay, you don't need to do anything. Then the last one is late D cell. Okay, late D cell. And so late D cell means that what? Placenta insufficiency. That is the cause of it. So you put this at the back of your mind. If you know this summary and you know the actions for each of it, then you are good to go. That is the VCHOP mnemonic. So for your, general intervention for non-reassuring fetal heart rate, what can you do? We said use the lion pit approach. So use the lion pit to also kind of a summary to help you remember how you're going to intervene. So the L is lay mother on the left. So position, then increase IV fluids. That is a I. O is oxygen. N is notify. P is pitocin. So discontinue pitocin or stop pitocin. This is not the order of how you should do it. This is just to help you remember. But like I told you, if the person is on pitocin, first one you do is to stop the pitocin before you come and change the position of the mother. But this is just for you to, remember what you do for your clients when clients are experiencing non-reassuring fetal heart rates. That is that on fetal heart rate monitoring and what we have to do. Any question, any input?
So, Master,
What do you do at the P? I don't get it. Amina, can you ask your question for me? I don't know what's the P. What do you want
The
to ask?
at the late deceleration, that's a
Uh-huh.
placenta insufficient. So what do you do then?
The same thing I said. So what I said here, you have to look at this action, okay? This actions here goes for all of them. The non-reassuring, you can so one, you look at is the fetus on the pitocin, and then the person is experiencing the late D cell. If the person is on pitocin, you stop it. If the person is not on pitocin, first is position. You administer fluid, oxygen, because we are looking at what you can do to improve placenta, sufficiency or placenta supply. And so IV fluids, oxygen, change of position, and then you inform healthcare provider. So this actions here goes for both late D cell and that of variable D cell, but it depends on what is causing it. And so in variable D cell, you have to look at it. Is there cord compression? If there is cord compression, you would have to lift the presenting part of the cord. That is an added action you can do in what you call cord compression. Yes. Any kindly mute up so we don't get any. So, Madam Amina, are you okay? All right. Any question, any inputs, any addition?
Yeah, I have some small question here. Yeah, with the early deceleration, you were saying that it's the fetus decelerate at the same time with the maternal contraction. How is it to be opposite with the late, as the late decelerate after the mother contracts, then the early will also be the decelerating comes before the mother contracts. But we are saying it happened at the same time, which I'm not.
I'm not getting what you are saying.
Okay, let's take the late deceleration that you said. The late means that the fetal heart decelerate after the maternal contraction, isn't it?
Yeah.
Am I right?
Yes.
But with the early one, you said that one happens at the same time with the contraction.
Yes.
I was thinking that maybe that one will happen.
No, so forget about the early. Forget about the early.
Okay.
I understand where you are coming from, but forget about the early. Okay, I just used that to explain for you to understand that in late D cell, the drop in fetal heart rate happens after the contraction had peaked and then it is returning or it's ending. That is where you have the fetal heart rate dropping. But in early happens together. So just take it that early deceleration happens together with maternal contraction. That is what I just wanted to understand.
All right. All right. Thank you very much.
Yeah.
Hello, sir.
Mm-hmm.
Please, with the early desal, does it need any intervention?
No.
Okay, thank you.
All right. I
Yeah,
said this.
hello.
I'm sure probably she was not here. Oh. Yes, I mean, madam.
Hello.
Yeah, madam.
I think I also have problem there. If something is compressing the head, it means the child is in distress.
Yeah.
So and
No, not something is compressing the head. It's not the head. So don't confuse me, Hajia. It's not the head. It's the umbilical cord. So now let me try to show you a picture for you to understand. Okay. Let me try to see if I can get a picture for you to see. Cord compression. So that you can see what I am trying to say here. Let's use this. Let's use this. Very good. So this is all that I have been. Even the first one here. This picture. So Hajia, this is what I am talking about. So this is a perfect example of. So this is called prolapse. Okay. And so this is called prolapse, where you have the umbilical cord. So this is the umbilical cord, right? So this is the umbilical cord here coming out first before the presenting part. Ideally, the presenting part has to come first before the cord, right? But in this case, you have the cord coming out first. And then this is the presenting part, which is the head. And then these are the soft tissues or the cervix, if you want. Here is a soft tissue. What are we seeing regarding this for those monitoring? What do we see? What do we see here?
is the head is compressing the cord.
The cord. So
Okay.
nothing is able to flow through the cord.
Okay.
So as a result, there is a decline, there is a sharp drop in fetal heart rate. Okay, and so this is where we talk about cord compression leading to variable decel. So this is what I was trying to describe for you to understand.
Thank you.
All right. Any question here? Any other inputs here? Yes. Okay, so our time is almost up. Oh, we've done almost 18 minutes into. Let me see if I can do one or two questions and then we drop it there for today. Then God willing, tomorrow we'll do a different thing. But if you have a question and you want to ask, you can ask. How do you lift the fetal? Okay, so you wear glove. So mostly you see the head out. Okay, it's not like you're going to put your hands inside there and then lift, but mostly you see the head visible. So you wear glove and then you lift the presenting part or you lift the head off the cord. You can lift it, okay. For a very better view, if you are using a real case scenario, usually you see, but if you cannot see, if the cord is not visible, so if the presenting part is not visible, of course you cannot lift it. So probably different, that's where position comes in. Okay, so if you can't see the cord, so if I show you the image again. Okay. So if, let's say, in this situation, you cannot see the cord, or sorry, you cannot visibly see the presenting part, which is the head, to lift it. I made mention of position. So in this case, when you do when you do Trendelenburg, when you lift the lower extremities, what happens? It kind of pushes the baby back. And so that can lift, or that can relieve the pressure of the cord. So it is not only one thing. You lift the presenting part when you can visibly see the presenting part through the cervix, or yes, through the cervix. But if you cannot see it, you have to use different method, position, which is ideal. I hope you're getting me, senior early that. Yes. Any other question? Okay, let's do this quickly. Then we'll drop. Maybe by 6:25, we probably have to end, so that God willing, tomorrow we'll take it from there. So let's look at this question. The nurse is monitoring a client in labor. The nurse suspects umbilical cord compression, if which is noted on the external monitor tracing during a contraction. These are easy because we just did, right? So let's answer this quickly. If you want to answer, you can unmute. You can also put your answer in the chat box, and then I'll read it out. Or we'll look at it today. I want to see 50 people responding. Oh, we are 51. Some people have dropped. We are about 58. About 7 people have dropped. So now myself, I was left with 50 people. So 50. I want to see people with 50 answers. Right.
So what is everybody choosing for?
What do you think, Ajia?
3.
Why 3? Read the question very well. It says that the nurse is monitoring a client in labor. The nurse suspects cord compression, umbilical cord compression. What do we think will be the cause, or what do we think will be the tracing to expect on the monitor? Okay, so it says that the nurse suspects umbilical cord compression, if which is noted on the external monitor tracing during a contraction. So it means that once monitoring the patient, what kind of tracing will you see on the monitor for you to suspect that the client is having umbilical cord compression, or there is cord compression ongoing? What would help you to suspect that? That is what this question is trying to say.
So,
Yeah.
So please,
no.
oh, somebody is talking of. So please, with the 3 that I said, the early deceleration, it means the cord has come earlier before.
No, Hajia is still not getting this. Forget about the early. Forget about the early. I said that the cause of early deceleration is when you have the presenting part engaging with the maternal pelvis. I made mention of this, that early deceleration indicates that the presenting part is what is coming first, which is good. And which means that part has engaged with the cervix, or the soft tissues and that of the pelvis, which is a good indication. And I made mention of what variable decel also means. So that is why you see people going for 4.
Thank you.
Musa, you are muted. Musa, you are muted. Musa, you are muted. Musa, you are muted. Let me mute the person up. Okay, so let's continue. All right. The nurse is caring for a client at 39 weeks gestation who is receiving an IV oxytocin infusion for induction of labor. The nurse notes recurrent late decelerations on the fetal monitor. Which of the following actions should the nurse take? Select all that apply. 1. Administer an IV fluid bolus. 2. Reposition the client laterally. 3. Discontinue the infusion oxytocin. Discontinue the IV oxytocin infusion. 4. Prepare the client for amnio infusion. And then 5. Apply abdominal vibrocaustic stimulation. Okay.
Samingo.
Yes, hello.
I'm not trying to read through the question, but this one, will it be appropriate for you to prepare the clients for amino infusion? Because
What?
it didn't state that. It
Uh-huh.
didn't state that the patient has maybe ruptured membranes or there is maybe
No, no. This patient is having late B cell. What causes late
just
B cell?
maybe basic
What causes
the
late B cell?
placenta
Placenta
insufficiency.
insufficiency.
So will you need to do amnio infusion in placenta insufficiency?
No.
No.
Uh-huh.
Okay. No, you try.
Soup. Inside where? No, for kitchen fridge. Soup dey there.
So
Tomato
that
rice.
is it. So you don't need amnio infusion in late D cell. Amnio infusion is needed in where? Variable D cell, when there is cord compression. That's where you need amnio infusion. So don't get confused, okay?
Thank you, sir.
Okay, so the
You go
last
make
one.
up.
All right. Okay. I know this question will bring a lot of twist here. Let's go on. The nurse is performing telephone triage with a client at 38 weeks gestation who may be in labor. Which of the following questions should help the nurse determine whether the client is in labor? Select all that apply. So you are going to apply what we learned through labor, forced labor science, right? 1. Do you feel like the contractions are getting stronger? 2. Does anything you do make the pain better? Then 3. Have you lost your mucus plug? 4. How frequent are the contractions? And then 5. Where do you feel the contraction pain most? Yes, I guys answering. Okay. All right. Seen people answering. 1, 2, 4, 5. 1, 2, 4, 5. 1, 2, 4, 5. Okay. I've seen a lot of people go for 1, 2, 4, 5. Others go for 1, 3, 4, 5. Okay, 1, 4, 5. Those who want to play safe game are going for 1, 4, 5. Okay. Okay. So who will want to take us through why he or she is going for that answer? Then we
Okay.
drop last there. Okay.
So I chose 1, 2, 4, 5. So you made mention that if for true labor, the contraction gets it becomes intense, and then the frequency is more the than the false labor. The false labor, the intensity is not very strong, and then the frequency is not too much, and then the location of the pain. How do you feel the contraction? Like, yeah. So that will come for the intensity, and then does anything you do make the pain better? That will go for alleviation of pain. Is it that when they walk about, the pain goes away? If they walk about and the pain goes away, then one goes for false labor. So it's not a true sign. And then the 5, where do you feel the contraction pain most? We made mention that with true labor pain, you feel the pain mostly at the lower back. But in false labor, they feel it in the abdomen or in their groin. So that one will make me. That's why I chose 5. So that will be a question that I may ask my patient. That's why I went for the 1, the 2, the 4, and the 5. The
Okay.
3, the reason why I didn't choose 3 is like losing of mucus plug is just at the start of labor. It's not an indication. It's an indication for labor, but not a true labor sign.
Okay.
Yeah, thank you.
Okay. Thank you. Thank you so much. You've done well. You've taken us through. You've tried to convince us. All right. Those adding the TV, who is ready to tell us why he or she is adding the TV? Anyone to do that for us? Oh, sorry. So this is it. So thank you, Bibi, for that's the perfect rationale, perfect answer. She defended it very perfectly, and that is it. Breaking of the mucus plug is not actually a true sign of labor. It can even break, some even break even days before labor actually sets in. And there are other things that can also cause the mucus plug to also even break. So it's not actually, yes, it for under normal circumstances, it should break as part of labor when labor setting. But we don't base on that to actually say that that is actually true labor signs. Like I said, it can break even days before labor actually sets in. And there are other things that can also cause it to break. That's not actually labor. And so for those who are going for 3, I wanted to know your side. Okay. So during pregnancy, you can have the fluid also breaking. I mean, like I said, even days before labor, sometimes days before labor setting. And so it's not actually something that when it happens, you say that, oh, this is just, I mean, an indication that the woman is just in labor. Okay. And so we will end our class for today here. And then God willing, tomorrow we meet and continue from here. Yes.